Good afternoon, everyone. My name is Eve Coopersmith, and I am a partner director at Garfunkel Wild. I want to welcome you to today's webinar regarding the long-term care requirements. We're going to be discussing Phase 2. I'm here today with my partner, Mick Stone, who drove down from Albany, so thanks for coming down today.
My pleasure.
I'm glad it's Friday, too, so I'm sure you all are as well. We have a fairly ambitious agenda today, as you may notice from the slides that we're going to get into. So our plan is to take questions at the end. On your screens, you should see in the upper right-hand corner a little box where you can ask questions. So as we go through the materials today, if you want to just add your questions there, we will get to them at the end of today's program, and we will reserve some time for that. So I'm going to get right to it and move along. Today's agenda is going to include a brief overview of Phase 1, Phase 2, and Phase 3 of the long-term care requirements. As you know, this was the first major overhaul of nursing home regulations in 25 years, and Phase 1 went into effect in November of last year. Phase 2 goes into effect in November of this year, and Phase 3 is for 2019. Today's main focus is going to be on baseline care planning, the specialized services that are required in Phase 2, a little bit on residents' rights and transfer discharge requirements, the facility-wide assessment, and the development of a quality assurance performance improvement plan. Slide 3 lists all of the different regulations that were changed as part of Phase 1. It was really quite of a big change, as you can see from all the different areas listed on this slide. And I'll just mention a few things that, about some of the changes that were made here with respect to freedom from abuse, neglect, and exploitation. As you know, there's a new definition of abuse now, which means a willful and deliberate act. There is no need to show intent. The term exploitation is a new term, and it means taking advantage of a resident for personal gain through use or manipulation, intimidation, threats, or coercion. There was a slight tweak in the definition of misappropriation, which includes deliberate misplacement, wrongful, temporary, or permanent use of a resident's belongings. So that's the kind of detail that you see in some of these regulations. You'll notice that quality of life was separated from quality of care. That was done to demonstrate that quality of life is a fundamental principle that has to apply to all of the facility's services. And as you know, it's a hot topic to focus on what activities a nursing home is offering to residents. They certainly should include activities that are within the facility and outside of the facility. Residents' rights had a lot of changes. There was much discussion about a resident's representatives and the fact that a resident may have more than one representative, and the resident retains for themselves all the rights that they don't appoint to someone else, or even when they have appointed to someone else, as long as the patient or resident still has capacity, they may still retain the right to make those decisions for themselves. And so this was a focus to redirect nursing homes not to simply go to the resident representative, but to recognize that the resident can speak for him or herself, and we need to respect those rights. So I'm going to move on because we have a lot to discuss regarding all of our slides here. With respect to Phase 2, Slide 4 lists all the different areas that are going to have changes in effect this year. We're going to be focusing on a number of these changes today, so we won't get too much into that now. I do want to simply mention with respect to the Elder Justice Act, this is not really anything new. This provision was intended to make the nursing home regulations coincide with the Affordable Care Act, and the requirements with respect to the Elder Justice Act went into effect with the Affordable Care Act. Certainly nursing homes should have already policies and procedures and notices for employees regarding the reporting obligations of crimes that are committed at the facility. And the only thing I want to mention particularly is the speed with which you must make the report. If there is serious bodily injury, you are required to make a report immediately and no later than 2 hours of the suspicion. And if there's no serious bodily injury, the report has to be made within 24 hours. Phase 3 requirements that go into effect in November of 2019 include the implementation of your quality assurance performance improvement program, but your initial QAPI plan is required for the end of this year. We'll talk about that today. The compliance and ethics program is required in phase 3, although I'm sure many of you already have one in place now because that's been required for some time, but the focus, of course, will be to ensure that that's done by phase 3. And there are many training requirements that go into effect in phase 3. So let's talk specifically about the phase 2 care planning requirements. And we go back a little bit to phase 1, comprehensive person-centered care planning, and the requirement that the facility develop a comprehensive plan that's going to include all measurable objectives and timeframes to meet the residents' medical, nursing, mental, and psychosocial needs that you're going to identify when you perform that comprehensive resident assessment. And again, back to residents' rights, I remind you that the resident has the right to participate in the care planning process, to identify the individuals that are going to participate, to request meetings, to request changes in the plan of care. The resident has the right to see the plan of care, and the resident has the right to sign a plan of care after significant changes. Remember that in phase 1, we have a requirement that a certified nurse assistant who has responsibility for the resident participate in the interdisciplinary team meetings regarding the resident, as well as a member of the food nutrition services. Now, there's been much question about, does everybody have to appear in person? And in the commentaries, CMS reflects that that can be challenging and specifically states that these meetings can be held in person. Individuals can participate by conference call, and if they can't be there in person, you can obtain participation via email or receiving written notes in advance of the team meetings. In our opinion, as a practice tip, we believe that the facility should document each member of the team's participation at the meetings, and if they're not in person, that's especially important. Moving on to slide 9, comprehensive care planning must describe services to be provided that will attain and retain the resident's highest practicable physical, mental, and psychosocial well-being. You see that language throughout these regulations and the commentaries. And of course, it's also important that in your care plans, you reflect not only what you're recommending, but the choices that the resident is making and the preferences. So you may have residents who they're entitled to choose both the frequency with which services are provided, the timing. Their goals and preferences must be reflected in the comprehensive care plan. And therefore, it's important to reflect both what you have recommended and what the patient's choices may be. And if there are any specialized services that have been recommended due to a pre-screening done for someone who has a mental disability or a developmental disability, it would really be a serious mental illness, you are required to document and incorporate those changes into your care plan. If you disagree with the recommendations made through the PASSAR review, you're required to document the rationale for your disagreement. Slide 10 refers to all the requirements of what must be included in addition to slide 9 of your care plan. And this has to do, again, with the resident's goals and desired outcomes. There's also been a shift in the regulations that focuses on discharge planning starting at the beginning of a resident's admission, and that there's a focus on incorporating and encouraging the residents' participation and the residents' representatives' participation in discharge planning. And so part of your comprehensive care plan must reflect that, the goals and preferences of the resident with respect to discharge and return to the community, and any referrals that are made to local agencies and entities in the context of discharge, and the discharge plan as may be appropriate. And there's a lot of requirements that were in phase 1 as to what must be included in the discharge plan, including a medication reconciliation. So in phase 2, with respect to care planning, this is when you're required to have a baseline care plan within 48 hours of admission. So come this November, you'll need to start implementing baseline care planning within 48 hours of admission, as well as the care plan summary, which must be offered to the resident at the time of admission, as well as upon request. So the care plan summary is required to be provided not only for the baseline care plan, but at any time during the resident's admission. So the baseline care plan must include the instructions that are needed to provide effective and person-centered care that meets professional standards of quality care. And it'll have to reflect the initial goals based upon the admission orders, the physician orders, and obviously medications, the dietary orders, therapy services, social services, and any PASAR recommendation if that's applicable. And because you're required now to start discharge planning, at the time of admission, you should also include in your baseline care plan the residents and their representatives' goals and preferences with respect to discharge. And I believe this is something that's going to be able to help you as you continue providing care to that resident, and should you have issues with respect to discharge in the future of that resident's admission, for example, someone who's going to go from a short-term rehab to long-term care, and you were not told that at the time of admission, it's important to be documenting this. This is your opportunity to document this at the time of admission. You're also required through other laws to provide information to residents regarding advance directives at the time of admission. So your baseline care plan should reflect whether the resident has any advance directives. Did they come to you with an interinstitutional DNR? Is there a MOLST form, a healthcare proxy, a living will? These kinds of things should be documented on your baseline care plan. With respect to a care plan summary, you must provide the summary to the resident and their representative in a form and format that they can understand. That's part of what a resident's rights are with respect to communication with the facility. So this slide 14 discusses what must be included in the baseline care plan, but remember that it has to be in a way that the resident can understand. It has to be plain English. I've been asked as to what if we just give them a copy of the care plan? Well, if you have care plans that are separated by each area of need, whether it be, residents' risk of falling or residents' pulmonary condition, it can be very confusing to a resident as to what that means. So, with respect to a care plan summary, again, it has to be in plain English and in a language that the resident can understand. We're recommending that in addition to providing the baseline care plan to the resident, that be a simple practice that you simply give it to the resident. And for some baseline care plans, if you're creating a new form that's relatively simple, that might be appropriate and easy for any resident to understand. If you've got a 2-page form, you can list all your services to be provided on a 2-page form and perhaps have a separate medication list. That might be enough to be in a format the resident can understand. I would provide that to the resident, and if they're not able to participate in the baseline care plan development, that's where you would indicate that on the baseline care plan and follow up with an invitation to participate in the comprehensive care plan meeting. So now I'm going to turn over the presentation to Mick, who's going to talk about the next set of requirements.
Good afternoon. I'm going to be discussing some of the specialized services that are to be implemented as of November 28th of this year. Those are behavioral health services, psychotropic drugs, and dental services. So the behavioral health services, with respect to it being a new requirement, I'd say it's probably more an enhanced requirement. CMS is of the opinion that the complying with the former regs under the 43.25F of the old regs, facilities should already be complying with many of these requirements. That being said, there are new things, which is, of course, why we're highlighting these. So each resident must receive and the facility must provide the necessary behavioral health care and services to, again, attain or maintain the highest practicable physical, mental, and psychosocial well-being. So again, there's that standard. So that's kind of the benchmark throughout. Services need to be in accordance with the comprehensive assessment and plan of care, which Eve just went over. Services must include the prevention and treatment of mental and substance abuse disorders as well. With respect to staff, the facility must have sufficient staff to provide direct services to residents with appropriate competencies and skill sets. Now, CMS is not requiring that the individuals providing the behavioral health services have any specific degrees or certifications, but the facility must have sufficient staff with appropriate competencies and skill sets to provide nursing and related services to residents in need of behavioral health services. So it's a recognition of, again, that this is a nursing or a nursing home or a skilled nursing facility, and that's its goal. However, staffing has to be competent in providing services to members of this population, those in need of behavioral health services. Also, with respect to the non-pharmacological interventions, and again, what CMS's position is that it's not taking an anti-medication tack in particular, but rather the intent is to discourage the inappropriate use of medications. So it's looking for those for staff to be trained in non-pharmacological interventions to make sure that the facility is not relying on pharmacological interventions in dealing with its behavioral health population. And again, so you're using the facility-wide assessment, which we'll get to determine your staffing needs. So the rehabilitation services for mentally disabled, this is mostly covered in the specialty services that were implemented in phase 1, the specialized rehabilitative services. So if you're so you have to provide the physical therapy, speech language pathology, occupational therapy, and rehabilitative services for mental disorders and intellectual disability. And so those are required to be part of the comprehensive care plan, and the facility must provide the required services, including specialized rehabilitation services, or obtain those required services from an outside resource. I think ideally, what CMS would like you to, what they would like to see is that it's from a Medicare or Medicaid provider. But in the commentary and then in the final regulation, they notice that might not always be feasible. So they've said that it need not be a Medicaid or Medicare provider, but that provider must not be excluded from any federal or state program. Also, I just wanted to mention with respect to, before I leave behavioral health services, there is a focus on dementia care. And recently, there was an MLN Connects national provider call that discussed and provided some guidance with respect to dementia care. And I think it kind of builds off of, there was a survey and certification letter 13-35-NH that also you may already be familiar with, that also discussed dementia care. So the regulations or the commentary on the regulations referred back to that. So If you are looking for guidance on caring for dementia residents, those are two good sources. One going back to that 2013 letter, and also the finding that national provider call that was just held. I think it was on March 21st or so. Okay, so the pharmacy services, the two primary changes in phase 2 with respect to pharmacy services are the monthly drug regimen review by a licensed pharmacist. It must include a review of the resident's medical chart. The CMS took pains to stress that that does not mean that you're doing a review of the medical. The physician needs to be involved in reviewing the medical chart every month along with the drug review. Rather, it's that the pharmacist has to take into account the resident's medical chart in doing that monthly drug regimen review. There's no specific time frames in the regs with respect to the DRR, obviously, other than monthly. But CMS does expect that the facility is going to develop policies and procedures that include, I guess, more specific time frames with respect to resident needs for drug regimen reviews. But monthly is the minimum. Also, there's new restrictions on use of psychotropic medications. So the psychotropics, they're defined in the regulations as antipsychotics, antidepressants, anti-anxiety, and hypnotics. They had considered opioid analgesics, but ended up taking that out. They determined it wasn't appropriate to deal with it in this. However, that's not to say that they did not acknowledge the importance of responsible use of opioids. So the pharmacy, so with respect to the psychotropic drugs, move on to the next one. Well, first, you're going to have your comprehensive resident assessment, and the facility must ensure that residents who have not used psychotropic drugs are not given them unless it's necessary to treat a specific condition as diagnosed and documented in the clinical record, and that residents must receive gradual dose reductions and behavioral interventions unless clinically contraindicated in an effort to discontinue these drugs. So again, the idea is to go with the non-pharmacological interventions with respect to those particularly the behavioral health population. With respect to the psychotropic drugs in particular and how they're dispensed, so no PRN orders are permitted unless necessary to treat a diagnosed specific condition that is documented in the clinical record. So for psychotropic drugs, and here it's underlined because, well, you'll see in the next one, it's distinguishing it from antipsychotic. So, but for the non-antipsychotic psychotropic drugs, the PRN orders are limited to 14 days, but if the attending physician or prescribing practitioner believes that it is appropriate for the order to be extended, they must document the rationale in the medical record and indicate the duration of the PRN order. So so that means, yes, that they're going to have to write a new PRN prescription every 14 days after the resident has been evaluated. Also, guidance is going to be developed. This is what I was getting at before. So PRN orders for antipsychotic drugs are limited to 14 days, and that's a hard deadline. Cannot be renewed unless the attending physician or prescribing practitioner evaluates the resident for the appropriateness of that medication. I should say that there is no exceptions for short-term residents, even though they would be returning to their primary care physician upon discharge. The CMS felt that protection was necessary for short-term residents as well. The dental services. So what you have to have developed, again, by November of this year is a policy that identifies those circumstances when the loss or damage of the dentures is the facility's responsibility. And I have to indicate that the facility may not charge a resident for the loss or damage of dentures determined in accordance with the facility policy to be the facility's responsibility. So that needs to be made clear to the resident. With respect to dental services, generally, the facility must promptly, within 3 days, refer residents with lost or damaged dentures for dental services. Now, that's the referral has to occur within 3 days. It's not necessary that the actual dental appointment or that the replacement of the dentures occurs within 3 days, but the referral has to occur within 3 days. If the referral does not, for whatever reason, occur within 3 days, the facility must provide documentation of what they did to ensure the resident could still eat and drink adequately while awaiting dental services and the extenuating services that led to the delay. So again, that is documentation that you will need to have ready in this sort of event. So I'm going to hand it back over to Eve right now to go over resident rights.
Thanks, Mick. With respect to residents' rights, some of the changes in Phase 2 include now that residents must be provided with contact information for the state and local advocacy organizations, including the State Survey Agency, the Long-Term Care Ombudsman Program, the Protection and Advocacy System for Persons with Disabilities in New York. That would include the Office of Persons with Developmental Disabilities, as well as the Office of Mental Health. You must also provide information about the Aging and Disability Resource Center and the Medicaid Fraud Control Unit. In addition to that, you're required to provide information regarding Medicare and Medicaid eligibility and coverage. This is already very commonly done at the time of admission. But these are all now absolute requirements. With respect to transfer and discharge, most of that regulation was changed in Phase 1. But in Phase 2, you now have to document the basis for the transfer or discharge in the medical record. And there's a specific indication as to who has to make the documentation. If the resident no longer needs the services in the facility because their health has improved sufficiently, the attending physician must be the one documenting the medical record. And the same is true if a resident's needs cannot be met at the facility. You are now required to document the specific needs that cannot be met, the attempts that you've made to meet the needs of the resident, and the services available at the receiving facility that can now meet the resident's needs. So there has to clearly be an attempt to address these issues. And I bring that also back to the whole behavioral health issues in particular, because there was much discussion about that in the commentaries, that if the resident is going to be transferred because the health or safety is threatened, then any physician can make that documentation because it's considered to be an emergent medical condition. So clearly, if the resident is engaging in fire setting or is becoming combative and violent, that would be something that any physician could document in the medical record, and that resident could be in New York. They could be 2PC'd over to a hospital, or you could call emergency medical services for assistance. But in the commentaries, CMS makes it very clear that the medical record must contain documentation as to the circumstances that occurred and what danger would occur at the facility if you did not transfer this resident immediately. So there has to be clear documentation as to the danger that is posed by the resident and by failure to transfer, or by not transferring the resident for care. In the new regulation, there are specific documentation requirements to have a smooth transition in care. The facility is now required to provide to the receiving provider all of the information that you see on slide 13. And the commentaries had expanded this requirement even further, but after receiving some comments, pulled it back to just this information, including the contact information of the resident's practitioner so that questions could be asked regarding the care needs of the resident, advanced directive information, resident representative information, including their contact information, special instructions. And the commentaries make clear that even in emergency situations, it's important for the receiving facility to receive all of the information that's listed in this slide, to have a smooth transition in care and to make sure that the residents' needs are going to be appropriately met and that they're going to have the proper medication and the proper services. The commentaries also reflected that facilities are encouraged to identify opportunities to streamline data collection and exchange by using data that's already captured electronically. So for example, if you have, as part of your MDS data collection, you may already have a significant amount of this information available. That is something that you can simply share with the receiving provider. And CMS indicated that they expect communication to occur shortly before or as close as possible to the actual time of transfer. Oh, sorry. I think we're moving it back over to Mick.
Okay, and I'm going to be talking about the facility-wide assessment really quickly. So the facility-wide assessment, it must address or include the facility's resident population, the facility's resources, and a facility-based and community-based risk assessment. So what you'll have to do is conduct and document, again, key document, a thorough assessment and analysis of your resident population, your staff and staff competencies, and resources to determine not only the resources that you currently have, but also the resources that you're going to need to obtain in order to care for your resident population competently. The CMS is promising guidance to assist with the facility-wide assessment. So hopefully we'll see that at some point soon. I think key to know again is what CMS is looking for is an actual formal documented process. So that's what you'll have to come up with. The resident population assessment includes, but is not limited to, both the number of the residents and the facility's resident capacity, the care required by the resident population, considering the types of diseases, conditions, physical and cognitive disabilities, overall acuity, and other pertinent facts that are present within that population. So again, you know, we referenced this when discussing the behavioral health services. So you'll have to account for your behavioral health population in this facility-wide assessment. So CMS is expecting that you're going to be objectively assessing your residents' needs ahead of whatever other concerns the facility might have with respect to cost or convenience of the operator. So just be aware of that. With respect to the population assessment, the staff competencies that are necessary to provide the level and types of care needed for the resident population, you're going to have to assess the physical environment, the equipment, services, and other physical plant considerations that are again necessary to care for this population, and also any ethnic, cultural, or religious factors that may potentially affect the care provided by the facility, including but not limited to the activities and food and nutrition services. So the facility's resource assessment includes, but is not limited to, the buildings and or physical structures and vehicles, your equipment, whether medical or non-medical, the services provided, such as your physical therapy, pharmacy, and specific rehabilitation therapies that we've mentioned, and all personnel, including managers, staff, both employees and those who provide services under contract, as well as volunteers, and their education and or training in any competencies related to resident care. So again, I think there's just 3 times that, so to put the drive the point home. What they're looking for is the sufficient competencies and skill sets, and not so much documentation of degrees or certifications. So just be aware of that. Also within the facility resource assessment is the contracts, memorandums of understanding or other agreements with third parties to provide services or equipment to the facility during both normal operations and emergencies. Health information technology resources such as systems for electronically managing patient records and electronically sharing information with other organizations. So the risk assessment, the facility assessment, as we said in the beginning of the third bullet, was must include a facility-based and community-based risk assessment, and this has to utilize an all hazards approach. So the idea is that whatever type of risk may be presented to the facility, whether natural disaster, whether man-made, has to be accounted for in the risk assessment. It should be noted that the risk assessment, I think this is important to note, the risk assessment is actually part of the facility's emergency preparedness plan, which actually must be in place and tested by November 15th, 2017. Now, November 28th, 2017 is the phase 2 implementation, but the emergency preparedness regulations that apply actually not only just to long-term care facilities, but was applied to all types of Medicare reimbursed facilities and providers, is actually the implementation date is November 15th, so it's a few days ahead of it. So this presents a bit of a burden because what they're expecting is that, again, it has to be in place and tested, meaning you have to do an exercise or document if you weren't able to do an exercise, involving your local community as well as internally. So be aware that that's out there, and that's something that you should get moving on if you haven't already. So these new requirements for risk assessments are more thorough than they have been in past, and your administrator, your director of nursing, and your facilities director should be involved on creating the risk assessment and the emergency plan. So the emergency preparedness plan, it has to include strategies for addressing emergency events identified by the risk assessment, meaning you'll be identifying those particular emergency events that you may be subject to. You're going to be addressing the resident population, including persons at risk, the type of services that the facilities can provide in an emergency, and that's with respect to, again, this is a community-based plan, so in the event that your facility might be able to take on residents who may be displaced by a disaster in the area, the emergency preparedness plan would address that. Continuity of your own operations, and including delegations of authority and succession plans. So there has to be in the plan also a process for cooperation and collaboration with local, tribal, regional, state, or federal emergency preparedness officials. And you'll have to develop policies and procedures, communication plan, which again, and I think they made a specific reference to, it has to be a HIPAA compliant communication plan, and training and testing based on the emergency preparedness plan. So the facility-wide assessment has to be reviewed and updated, and again, this is including the emergency preparedness plan as necessary, at least annually, and whenever there is or facility plans for any change that would require a substantial modification of any part of that assessment. Moving on.
So let's talk a little bit about the quality assurance and performance improvement requirements that have gone into effect in phase 2. As I mentioned before, implementation of the QAPI program will be phase 3, but you must have your plan and policies and procedures that will be available to provide to a state survey agency no later than this year. It says October 4, 2017. Now we've asked for some clarification on that exact date. but it is this year. We know for certain it is certainly this year. And you're going to have these plans available at any time a surveyor requests them. In phase 3, you'll have to show documentation of the implementation of your QAPI plan, including the projects that you're working on that are for performance improvement. So there's a lot of material available on CMS's website about how to develop a QAPI plan. And there are 5 basic elements: design and scope of the plan, the governance and leadership. And with respect to governance and leadership in particular, the governing body is responsible to ensure that the QAPI program is defined, implemented, and maintained, and sustained during transitions in leadership and staffing, so that anybody who comes into your facility will be able to look at your QAPI plan and be able to move forward on that. The leadership is required to identify and prioritize problems that are based on performance indicator data, to reflect the organizational processes, functions, and services, and to set clear expectations around safety, quality, rights, choice, and respect. The plan should also have a program on feedback, data systems, and monitoring. And we'll talk a little bit about that in a moment. The Quality Assurance Committee has to include the medical director or a designee, and at least one person in a leadership role must serve on the Quality Assurance Committee. And the Quality Assurance Committee reports to the governing body. Again, that goes back to leadership. Performance improvement projects have to be identified as part of this QAPI plan. And we'll talk a little bit about how that may get implemented and triggered by your facility assessments. And lastly, a good QAPI plan will have a systematic analysis and systemic action plan to address areas of weakness. So with respect to design and scope, the program has to be comprehensive. It has to deal with a full range of the services that are offered by your facility and be data-driven with a focus on quality indicators of outcomes of care and quality of life. Again, you're going to be looking at some of your facility assessments to determine what your care needs are and where your weaknesses are in finding sufficient staffing to meet the needs of all residents. The data systems you must have data systems that are going to be able to maintain evidence that you are in fact implementing this plan and maintaining an ongoing program. Performance improvement projects should be focused on high risk, high volume, or problem-prone areas, and they have to be facility specific. So if you are finding that you have frequent resident falls, that might be a facility specific area that you want to do a performance improvement on. The recent MLN Connects program was on quality performance indicators with respect to dementia, improving dementia care in nursing homes, and implementing a performance improvement project to decrease the use of psychotropic medications and improve care for dementia patients overall. So these are the kinds of performance improvement projects. You must have a performance improvement project annually and or more frequently as needed. It is not limited to an annual performance. The systematic analysis and action must have, and these are things that are going to come out also through your Quality Assurance Committee. You have to have systems and reports that are going to demonstrate the identification, reporting, investigation, analysis, and prevention of adverse events, and documentation demonstrating the development and implementation and evaluation of corrective actions or performance improvement projects. And these are all part of a good QAPI program, and the plan should have this in place as to how you're going to go about implementing policies and procedures that demonstrate a proficiency in the use of the root cause analysis when you have a root cause analysis from an adverse event. The policies that you will need will include policies and procedures for obtaining feedback, data collection systems, the development, monitoring, evaluation of performance indicators, and reevaluation of your system to develop and monitor and evaluate performance indicators, as well as the adverse event monitoring. CMS expects that you're going to have a wide variety of data collection systems so that you can obtain the most information that's relevant with respect to your quality assurance measures. The specific requirements for policies and procedures that are mandated include the maintenance of systems to obtain feedback from direct care staff, other staff, residents, and resident representatives. And on this last slide here, I wanted to indicate the email addresses to ask questions. There's a specific email address for questions regarding the QAPI plan and program, which is on slide 49. For general questions about the CMS new requirements, you can email the survey development site that I have here. For New York State, interpretive guidance is expected in May. We'll see whether that happens, and we have the email address for asking questions of the New York State Department of Health. The last indication that we have for interpretive guidance from CMS regarding the requirements is that something will come out this summer, and we'll continue to follow for that. So now I'm going to open up the field for questions to see what questions will be asked. The first question that I see from several people are we going to be sharing the slides? Yes, the slides will be posted at the conclusion of our program. The presentation will be posted to the Garfunkel Wild YouTube page, and we will send an email to all registrants with the link to the YouTube page. And so there'll be the slides will be available as well. Let's see other questions that we have. We have another question with respect to the facility assessment. If the resident mix changes significantly during the year, or the facility hires new staff or makes other changes, what was included in the assessment, does the facility have to update the assessment at the time of the change? Mick, I'll let you answer that.
Okay, yeah, well, what the regulations specifically require is that the assessment be reviewed and updated if necessary on an annual basis. The annual assessment is a minimum requirement, so facilities obviously aren't prohibited from updating it more frequently if they so choose. So if it's necessary, then they should probably do that.
I see another question with respect to behavioral health services. Will the facility now be required to admit residents with serious mental disorders and make available specialized staffing to meet their needs? The regulations don't require that long-term care facilities admit any resident for whom the facility cannot provide appropriate care. The nursing home is expected to perform a facility-wide assessment, as we talked about before, which will include an assessment of resident populations and the diagnoses and conditions of all their residents and the severity and acuity of those conditions, and to have appropriate staff to provide services. But you're not required to admit a resident for whom you believe you do not have the services available to provide appropriate care.
Okay. There was another question with respect to guidance on the emergency preparedness requirements. There was a recent survey and certification letter, 17-21-all, because again it went out to all providers. So it acknowledged that it had promised guidance in the spring of 2017 with respect to creating your emergency plan. However, it stresses in that letter that, well, it actually says, we realize that some providers and suppliers are waiting for the release of interpretive guidance to begin planning these exercises, but that is not necessary, nor is it advised. So CMS is expecting you to do these, get these exercises underway, notwithstanding the fact that specific guidance hasn't yet been provided. They did, however, in that letter have links to resources that they believe would be helpful to you. And again, that letter is Survey and Certification Letter 17-21-all, and it just came out on March 24th.
I see we have another question about the documentation that is required on transfer or discharge of a resident, and what is the expected time frame. Can it be forwarded before, does it have to be forwarded before a resident is transferred to a hospital, or can it be forwarded after, particularly if there's an emergency? In the commentary, CMS makes it clear that even emergencies are important for the information that's required to be communicated, but they recognize that the emergency is, of course, the paramount concern, and that the material can be transmitted following transfer of the resident to the hospital, but it should be done as soon as possible. Otherwise, CMS does expect that the documentation would be forwarded in advance or with the resident on transfer or discharge. Let's see.
And there's another, there's a QAPI question for you.
There's another question regarding how different the QAPI concept is from your current QA program. It is very different. Your current QA program looks at adverse events and responds to those adverse events, and I'm sure you have a committee that looks at and focuses on certain indications. But the QAPI program that CMS envisions is a much more in-depth program that not only are you being reactive, but it's proactive in formulating and developing areas of focus that are high risk or high volume areas to improve quality of care for all residents. So it's a very in-depth program, and I would recommend that you go to the CMS site to see just how comprehensive this program is. It's supposed to include all systems of care and management practices, not just clinical care and quality of life, but also things like resident choice and resident rights. You have to define and measure goals. And so you need to have a written plan that is going to also adhere to those principles. Let's see other questions that we have.
So there was a question about the difference between a community assessment versus facility assessment for risk management. So that goes back to the emergency preparedness. So it actually reads a facility-based and community-based risk assessment. Again, there's the language in the facility-wide, the regulation with respect to a facility-wide assessment, and that for emergency preparedness, it's essentially the same language. The idea for the community-based is that the facility is to involve the larger community, the larger surrounding community as well with respect to its emergency preparedness plan.
We have a question as to the summary care plan, regarding the requirement that the resident receive a summary of the care plan? Can we just provide to the resident a copy of the care plan? As I had said before, the resident has the right to receive information in a form and manner the resident can understand. If the care plan is straightforward and that you believe it's something the resident can understand, then that might be fine. But residents are allowed to ask for all information to be provided in an alternate format and language, and most comprehensive care plans are multiple pages and would be somewhat confusing for a resident to, for a layperson, any layperson to understand. Creating a summary with a copy of the medication list would be necessary to comply with the comprehensive care plan summary requirement, because it is a summary. I'm looking to see what other questions we have. It's a little hard to read the screen. We have a question regarding transfer to a hospital, and is one incident sufficient to form the basis or justification for transfer, or do you have to have repeated safety issues with a resident to justify? I think that's a question really for what the nature of the safety concern is. If the resident poses, if their behavior is such that it cannot be appropriately redirected and managed, then you may have enough, depending on the nature of the emergency, to send that patient to a hospital right away. However, if this is a patient who has a mental disorder and you're aware of the symptoms and as they may appear, certainly making attempts to work with that resident and redirect that resident and manage that resident in-house would be appropriate. Because otherwise it's likely that resident, if they don't really meet the criteria for inpatient admission, they're going to bounce right back to you. But naturally, when you have any kind of emergent issue and that does threaten safety to either the resident, to themselves, or to others, that is something that's going to require your immediate intervention, and it'll be up to your staff to determine whether it's enough to send that person to a hospital. CMS is not commenting on that in these regulations.
And it looks like there's another question with respect to trauma-informed care or post-traumatic stress disorder with respect to behavioral services. That's a phase 3 requirement. So you will be expected to have staff with sufficient competencies in caring for residents with a history of trauma, or for a post-traumatic stress disorder. Again, phase 3 is November 28th, 2019. That's ways off, but it is expected that by that time, part of your behavioral health competencies and skill sets will have to include competencies in that population, those with histories of trauma or PTSD.
And we're just at the end of our program, so I want to thank you. If there are any questions that we haven't gotten to, and I do see that we may have a couple of left here, we will respond to the questions that are posed following the program. So I want to thank everybody for participating today, and wish you all a good weekend.